welcome back from your break. Hopefully you were able to get up and stretch a little bit, and then we'll get right back into this. So we've talked a little bit about some of the foundations of effective supervision and some of the considerations that we have to have. And this was brought up in the chat, that it's not just about what you know. What you know is important, but it's about how you bring that to bear, because these are such complex cases. Your effectiveness as a supervisor, and ultimately your supervisee's effectiveness as a clinician or counselor, is dependent upon how you translate that knowledge into an opportunity for connectedness, an opportunity for a relationship, an opportunity to convey to the individual that you're working with that they have value, that there is some opportunity for recovery, some potential for that. And so to that extent, I want to spend a little bit of time just on knowledge. And I'm going to go through this fairly quickly, but I think this is foundational enough to what we're talking about that it's worth going over. There are two main reasons that people take drugs, to feel good or to feel better. And so I want to talk about understanding our current conceptualization of substance use issues. We currently conceptualize this as a chronic relapsing disease of the brain that affects reward, memory, attention, motivation, and related circuitry. Related circuitry, because there's a whole lot more to the brain than just those four components. But when we think about this from a behavioral standpoint or a mental health standpoint, a cognitive emotional standpoint, there are really two main reasons that people take drugs. They may come by it in different ways, but it's either to feel good, to enhance an experience, or to feel better, to feel less bad about something. In other words, a major reason that people take drugs is they like what it does. Take a drug is that they like what it does to their brains. And so really quickly, I want to show a video. You all are familiar with dopamine. You know what happens in a normal dopamine transmission process, but we're going to take a look at this video really quickly. This is a video I've actually used with clients, not just supervisees or trainees. And I've got a pretty good response from some of the clients when they've seen this set of videos. But we're going to take a look first at what happens in the brain with normal dopamine transmission.
Our brains are finely tuned machines. Inside, cells called neurons are constantly communicating to shape how we think, feel, and act. Let's eavesdrop on their conversation. These are the ends of two neurons. The one on the right sends a message, and the one on the left receives it. At first, they look connected, but they are actually separated by a tiny space called a synapse, where messages are relayed. What we'll see next is how we normally experience pleasure. The sending neuron contains dopamine, the brain's pleasure chemical. When something good happens to us, this feel-good chemical is released into the synapse, where it connects with receptors. There, dopamine activates the receiving neuron, which in turn conveys the message onto the next neuron, creating a chain reaction that produces pleasure. After the message is sent, dopamine is recycled by transporters to be reused. This conversation repeating itself again and again gives us the feeling of pleasure.
Okay, so what we know, and this is based on animal studies, is that when an organism is put in a particular condition, dopamine production will increase. And so really quickly going through these slides, here we have a condition in which you have a normal baseline output of dopamine. You administer food in this situation to a rat, and you see a spike in dopamine. Similarly, you put another rat in that cage, the rats do what the rats do, and you see another spike in dopamine. And what this tells us, what I usually say is that this tells us that sex is worth 1.5 cheeseburgers. I think that's mathematically what we determined from this. But what this really tells us is that in certain circumstances, dopamine is produced as a means of saying, hey, this feels pretty good. We should do more of this. So there's a reinforcing component. But moreover, it's tied to specific behaviors that are implicated for survival. Food is necessary for the individual to survive. Sex is necessary for the organism to, or the species to survive. And so you see the way in which dopamine is tied specifically to motivation. And it's not just motivation to feel good, it's motivation for fairly fundamental behaviors. What happens when we throw methamphetamine into this mix?
How does meth change our brain? When we use meth, it enters the bloodstream and travels to the reward center of the brain, where it invades the sending neuron. Meth causes dopamine to unnaturally leak into the neuron, then spill into the synapse. Making matters worse, meth blocks the transporters, which recycle dopamine back into the sending neuron. This keeps levels abnormally high, overstimulating our brains. We feel a powerful wave of pleasure. The rush can last 8 to 12 hours from just one dose.
So slightly different process with methamphetamine, and we actually see this spike in dopamine with almost every substance that's used recreationally. Our little rat friend has a long day of doing research. He goes to the bar with his other rat buddies, has a drink, and you see that spike up in dopamine. He goes outside and has a smoke, you see that spike up in dopamine. And so it begins to make sense from a behavioral standpoint why certain behaviors are paired together. Food and alcohol, food and a cigarette, sex and alcohol, sex and a cigarette, alcohol and a cigarette. You'll notice that the scale changes ever so slightly when we take a look at cocaine, and the mechanism of action is a little bit longer. If we throw methamphetamine into the mix, what I want to draw your attention to, focus on that scale. Whereas cocaine goes from 0 to 400, methamphetamine shoots up to 1500. There's nothing on this planet that's going to produce that level of pleasure naturally. And so when somebody comes into treatment, what we have to think about is, what are the interventions that we're recommending? How do we conceptualize our initial approach? Moreover, how do we help supervisees understand their approach? Because it is complex, because there is so much going on. Saying, you know what, just take a walk, go out, well, previously, before we could do this a little bit more easily, take a socially distanced appropriate walk. Go outside, watch the sunset, do some deep breathing. That's not going to be sufficiently powerful enough to replicate the feeling that the person was getting. And so I have to think about this impact and the way in which this impacts the interventions that we would recommend, the power of the interventions that we would recommend initially in treatment. The other thing that we notice is that this area of the brain is overactivated. This area that's highlighted here in orange and red, that's going to be in the limbic system. That's the amygdala. Amygdala is responsible for emotional processing and regulation to some extent. Overactivated. The area that is underactivated here, the blue area, prefrontal cortex, executive functioning, decision-making, planning, inhibitory control. All the things that we want people to be able to do in treatment aren't going to be functioning at a neurological level that we would want when they first come into treatment. And so it's no wonder that people will fly off the handle, they'll get upset, or they won't do the things that we so carefully planned out with them. Their brains neurologically are not structured to respond to those kinds of prompts. And if you look at the neurological activation pattern of something like PTSD, you have overactivation of the amygdala, you have inhibition of the prefrontal cortex. So I have to keep this in mind when I'm devising treatment plans with a supervisee. It's not enough to come in and say, do this, 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 and this. You're going to attend a group on Tuesday. You're going to go to your doctor on Friday. You're going to bring your Medi-Cal card on next Wednesday. You're going to show up for your appointment on time next Tuesday, even though you have to take 4 buses to get here. And they show up on Monday at 1 p.m. and we're like, what happened? You haven't done anything we talked about. Their brains took what they could from all of that information and did the best that they were able to do with managing what they were able to cognitively at that point in time. I need to tailor my interventions to meet people where they are neurologically. Drugs change the brain in fundamental and long-lasting ways. We have evidence that those changes are structural as well as functional. People in meth-using conditions, so compared to controls, do worse on picture recall and word recall. That's not too big of a surprise. But what we see is that they do significantly better on picture recall than word recall, almost consistent with the control group. So that tells me that maybe I need to change the way in which I present information in treatment. What I typically do is people come in and I say, hey, welcome to therapy. Here's an 18-page packet of paper that you need to sign. Go ahead and read that on your own or take it with you. And then I'm going to talk to you for the next 2.5 to maybe 3 hours to understand everything that's going on in your life. And then I'm going to tell you what we're going to be doing from this point forward. That's not going to stick. I need to find some way to, again, meet them where they are represent things visually in a way that's going to better grab their attention, better attend to the cognitive impairments that might be present. Does this last forever? It does not. Because of neuroplasticity, the brain has the opportunity to grow and change in different ways with appropriate support and abstinence, but it takes about 2 years. So you'll see that about 1 month post-detox, an individual who's using meth will have significantly reduced functioning in the dopaminergic system of the brain. At about 2 years, starts to look about the same as baseline, but we know that the connections that are reformed aren't necessarily exactly the same. So we have to be aware that some of these changes may persist long after the drug use has stopped, and it changes the brain in fundamental ways. This often occurs once the person has passed the point of compulsive drug use. But what this tells me is that this is a chronic ongoing issue that people may experience, meaning it doesn't work for me to conceptualize a substance use issue as a single episodic point in time. I have to think about it as a continuum. And this is how the DSM-5 has reconceptualized substance use issues. No longer do we refer to it as substance abuse or substance dependence. One of the reasons is diagnostically, that doesn't really give me a lot of information about the person's overall functional impairment. It gives me a snapshot at a point in time, potentially, related to one particular substance. But I want to understand in an ongoing way, what are the challenges that need to be addressed, and how do I incorporate that into treatment? There's also been movement away from the term abuse, and I'll talk about that in just a second. So think about how you might modify your treatment. And this is a good recommendation for co-occurring disorders because of the numerous cognitive impairments that individuals may experience. You want to think about reducing substance use potentially rather than total abstinence. You want to think about restructuring your sessions so that you're decreasing the amount of time that you're spending talking at someone. I think adults can generally retain new information for about 16 to 25 minutes. I think we have this information from students who are studying. You should be taking breaks after that. Having somebody in a 90-minute group is way too long. Structured breaks don't have to be lengthy. It's not 20-minute break. It's let's do a different activity. Let's take a step back. Let's do a mindfulness activity rather than working through our workbook. And this kind of structure and focused attention on session planning models consistency, predictability, and structure for the clients, which is going to be critically important in enhancing prefrontal cortex functioning. So if we're planful about how we deliver these services, that actually neurocognitively creates and strengthens connections that are going to be beneficial for recovery. In supervision, I want to make sure I'm helping my supervisee be really, really planful about how they're delivering these interventions, especially early on in treatment. Using memory aids, that's great. Represent it visually. Mindfulness has been shown to be incredibly impactful in substance use treatment as well as for severe mental illnesses. Putting things in writing is great. Again, if you can visually represent it, that is fantastic. And so think about how you might develop these maybe outside of the box interventions in a structured way with your supervisee so the supervisee feels supported with a plan to deliver with the client. All right, Maggie mentions that she sees a lot of herself in her client. They grew up in the same part of town and even went to the same high school, though at different times. She feels certain that there are probably some common social connections between her and the client. When describing the client's experiences of anxiety, Maggie notes, that's just how things are in our culture. There's a level of, I have to handle this myself, and talking about it would make my family think I'm weak. And of course, Maggie says, there's always alcohol at all the gatherings with the family. That's just the way life is. It's no wonder the client is drinking, but we can't just expect her to push her family away. How would you address this with Maggie? How do you address the cultural piece that Maggie is bringing up? What would you say to Maggie? What would you focus on in trying to move Maggie forward in assisting this client? What concerns would you have as well? And as you're responding to that, I'll take a look at the chat. Not to be the cynic, but are the interventions waiver friendly from a billable perspective? Jamie, very, very good question. these interventions should be billable from a waiver standpoint. We can get into that a little bit more offline potentially, but I'm assuming you're talking about the ODS waiver. These are all CBT interventions. These are all CBT interventions that are driven from foundational CBT information, and so that is a cornerstone of recommended treatments under the waiver, and so that should be something that would be billable and reimbursable. Again, we can talk more about that if needed. Right.
Well, I would want to know for Maggie if she has actually had a conversation about the client's culture, or if this is just her assumption based on her own experience, because that are two very different things. If she has had that client's conversation and this is a reporting of the client's experience, then that absolutely, of course, we're balancing the client's desire to have her family in her life, and as well as addressing the alcohol use. However, if it's simply, well, how it was for me, so therefore it's the same for all clients, then that's something that needs to be addressed.
Great. And you see the double-edged sword that culture presents. Whether we're talking about culture related to race and ethnicity, whether we're talking about community culture, whether we're talking about recovery culture, that it may provide a level of insight, but we're back to that idea of it is not one size fits all. And if you've had this conversation with the client, fantastic. There might be some blurring of boundaries here. We might want to assess how close this connection is. Certainly, it sounds like there's some countertransference. If you haven't had this conversation with the client, in no way should we be presuming that your experience is the same, even though there is this commonality. And this particular supervisee, we had a really difficult time pulling back on the separation between client and provider, to the extent that at one point it went to the level where Maggie was actively trying to pair this client with I think it was one of her uncles for work. And so it escalated very, very quickly because there was this really, really messy overlap. The other thing that I think Maggie might need some support in addressing and processing her own things in therapy. That's good. A lot of countertransference. Maybe she shouldn't be seeing this client. This again could be a really great opportunity for Maggie to learn about setting appropriate boundaries and how to do that, how to recognize culture and be culturally informed, but to not have that leak into her clinical judgment or determinations. The other thing that we recognize is that Maggie's using her culture as a means of minimizing the impact of substance use. That anecdotal information, culture is critically important, and I think it was H.N. Sylvester. You mentioned that I don't want to take her away from her family. I don't want to ignore the part of culture that's important for the clients. But when there's that normalization that occurs, whether it's through experiences, anecdotal information, or culture, if that starts to minimize our ability to accurately assess, that becomes problematic. Lori says, Maggie is over-identifying, making excuses. Yeah, good. Give her the tools to still connect to family, critically important. She can attend the family gathering, have soda, stay away for a while, and leave the party a little early. Great, all really good suggestions that help us identify ways of navigating the substance use. But it requires Maggie to recognize that before we even get to the appropriate delivery of that with the client. And so there's a lot of work that I have to do in supervision to make sure that I'm taking into consideration Maggie's culture, but also the boundaries that she's setting with the client, as well as her appropriate clinical assessment in this case. Help her identify countertransference issues or transfer her to someone else if it's unmanageable. Good, really good discussion. Again, just a really quick note, empirical literature found that anxiety disorders tend to precede substance use issues. Mental health disorders can lead to substance use issues. Substance use issues can also lead to mental health problems. Marijuana use increases the risk of psychotic disorders. in individuals with a specific genetic predisposition, but they're also finding that it increases the risk for any adolescent use. And there's more and more research that's substantiating that. Basically, what we're talking about here is there are a lot of overlapping risk factors that we have to consider. It's not just about the brain. There are genetic vulnerabilities, there are environmental factors that we have to consider, there's culture to consider, stress and trauma play a role. All of this comes to bear, and it makes the separation of the task that a supervisee has a little bit messy. So we have to come back to this idea: how do I stay structured? How do I stay predictable? How do I stay consistent as a means of establishing a baseline to enhance prefrontal cortex functioning in treatment? And working with a supervisee to do that hopefully might reduce some of the blurring of boundaries or some of these extraneous factors, some of the countertransference issues that may be coming up. Some of the examples of treatment biases that we might have to address in supervision: people have biases that they may not be aware of: homelessness, poverty, medical issues, mental health and personality issues, recommending treatments for opioid use issues that are not consistent with an individual's own experiences, LGBTQ considerations, social, religious resistance, and then working with patients culturally different from yourself. Even, again, if you're from the same block, if you grew up with near that individual, if you have similar experiences, your experience is not the same. And so even if there is that similarity, we're always going to be culturally different in different ways. At the very least, we have role difference that we have to be aware of. This is an activity that we tend to do in some of our cultural humility trainings. You're visiting with your sister after a recent visit to the doctor for numbness and tingling in her feet. She says that her doctor told her she has diabetes and that she's stupid for letting her diet get so out of control. The doctor's recommendation is that she see a dietitian and gain some self-control. Once she does that, he'll consider treating her diabetes directly with medicine. The doctor tells her that treatment with insulin will do her no good unless she's really ready, and he'll know that's true when she actually starts making changes and losing weight. The doctor tells her to come back when she's really ready to change. No follow-up appointment is scheduled. Oftentimes the reactions to this vignette are that doctor should not be practicing, that this is entirely inappropriate, that people want to know who that doctor is so they can file a formal complaint. Again, this is a made-up scenario, but it's not entirely unheard of. The reason that we present this is to think about the impact on your sister. At the very least, your sister's going to feel shamed. She's going to feel like she's not going to go back to that doctor. She may not make those changes, and she's probably less likely to talk about what's actually going on the next time she does see a doctor. Now, this seems unheard of, the way it's presented, but if we were to shift this vignette to instead of talking about diabetes, change this to being related to substance use, this type of interaction still occurs in the treatment field. It occurs with physicians, it occurs with mental health professionals, it occurs with substance use professionals. And there are holdovers in the field that believe that the best way to get somebody to move towards recovery is to shame them and to make sure that they feel like they are not doing enough, denying certain medicines, denying certain tools to facilitate that. And so we have to be very careful about the way in which we conceptualize engagement, and we have to be aware of biases that might come up with our supervisees because of information that they may have heard, because of their experiences. Words and attitudes have significant power. The way that we say things are critical in treatment. Stigma comes up in all sorts of treatment. We want to be very careful not to perpetuate stigma. We want to be really careful that we're not using terms that inadvertently perpetuate a client's shame. Alex has a great way to describe how many programs and staff address substance use. Yeah, we see that really, really frequently. I think I've heard somebody bring this type of approach up within the last 2 months of doing trainings. In the chat, an example of this in adolescent treatment is, don't even call me or come if you're using. Yeah, we see some treatment programs where they'll actually have clients sit on the floor while the counselor still sits in a chair above everybody else. And so while there's no verbal exchange of stigma or shame, we're still replicating those dynamics. No other medical condition is shrouded in stigma like that of substance use disorders, but we see this across a number of different chronic conditions. And words really do make a difference. They've done studies where 2 different groups, if I were to separate you into 2 different groups You get the same information. One person is referred to as a substance abuser. The other client is referred to as having a substance use disorder, and there's no other information given about this hypothetical individual. The substance abuser was seen as less likely to benefit from treatment, more likely to benefit from punishment, more likely to be socially threatening, more likely to be blamed for their substance-related difficulties, and more able to control their substance use issues without any sort of help. If that's the kind of bias that we have from using even just that slight change in term, abuser versus substance use disorder, how does that translate to the kind of interaction we have with someone in treatment? Now, substance abuse was a previously relevant term in DSM-4. It's since changed to substance use disorder. There are still holdovers to that. We are the integrated substance abuse program. That's not changing anytime soon because of the paperwork to have to change that to appropriately. But in interactions with individuals, we have to think about how do we minimize even small occurrences of bias that might come up. My friend is a drug addict. She can't seem to get clean. Our community has a serious drug abuse problem. This doesn't really fit with our conceptualization of the neurological basis of substance use issues, that it's a chronic, ongoing neurological disease, not unlike other chronic illnesses. So we look at using more affirming language. And this isn't just about being PC or trying to split hairs over the kind of language we use. It really does translate to creating a more affirming and strengths-based environment for our clients. My favorite example, I think, that I've encountered more recently, but not the first time, during clinical case consultation, multiple treatment team members provide an update on a client, Susan. Susan has been admitted to treatment in residential care for a history of alcohol use disorder, bipolar disorder, and an extensive trauma history. Treatment team notes an incident from the past week in which Susan was non-compliant with treatment team instructions, running out of a room after hours and leading staff on a chase. Sounds very one-sided from my perspective. She was completely unresponsive to any attempt to talk to her and wouldn't follow facility rules. The third time this has happened since she's been here. Another of the treatment team staff make a joke about how Susan is just too privileged to do the work necessary. The staff laugh, and another remarks, "This is just how borderlines are." But we're the ones who have to deal with it. Throughout the consultation and afterwards, your supervisees will refer to Susan as the borderline when talking with each other. This seems to be one of the most common applications of a label to alleviate staff anxiety, discomfort, or frustration. I hear this all the time in supervision. Oh, that parent is borderline. Oh, that client is borderline. Almost as if that is a way of attributing the difficulties of the case and resolving them by simply applying that label. Within an appropriate clinical diagnosis, fine. Totally okay with identifying symptoms related to a diagnosis of borderline personality disorder. But this type of kind of off-the-cuff use of labeling doesn't serve to enhance anybody's ability to engage a client or to see an opportunity to clinically assess outside of preconceived notions. This also shows up in treatment planning. We want to make sure we're not using language that's not clinically appropriate. Client is in denial. Again, that is stigmatizing and puts a lot of the onus on the individual to have to suffer more before they're willing to change, which I don't really appreciate as a conceptualization as somebody who's wanting to help a client. Again, heroin dependent is a little bit outdated. Diagnostically, reports being fairly promiscuous. Promiscuous is a very loaded term, and it doesn't tell me anything about behaviors or risk related to those behaviors. Client is on probation for being an alcoholic. Alcoholic is not a diagnostic term. Client is schizophrenic. This one, again, I see this fairly frequently. People are not their diagnoses. An individual is diagnosed with schizophrenia, but to equate an individual with a diagnosis, I think, overly reduces the potential to see that individual's strengths. R. Bolter in the chat, always treat someone with dignity, I think is a good rule to take away from this conversation. Client has been smoking a lot of weed. Again, not too big of a deal, but we want to make sure we're using correct terminology, clinical terminology in assessment planning. Some additional steps for relational focuses to try to bridge the gaps that we're talking about here between the practical focus and the conceptualizations. Having an open door policy is great. I think it's a good way to facilitate feelings of comfort and letting people know that you're available. Still respecting a hierarchy of reporting is going to be important to maintain that kind of structure within an organization, but letting people know that you're available is a great way to facilitate that level of comfort. Always pursue additional training on relationship building, interpersonal competence, and conflict resolution. And then sponsorship, acceptance, and confirmation, and increasing the amount of supervision is going to be important when you're thinking about this relational focus. A couple questions that have come up in the chat in a few different ways. You'll have access to this PowerPoint after the training. You're welcome to use it for your own training purposes, just giving appropriate credit. I'm also going to try to get those videos to you all in one form or another, whether it's embedded in the slides or as a separate YouTube link. We'll make sure that you have that for your use with supervisees or clients, or even for your own training. The clinical supervisor as a mentor is one of the ways that is hypothesized to play a role in reducing conflict within supervision. Supervisors recognize that counselors, particularly in substance use work, have high levels of work, non-work conflict. The things that are happening outside of work impact your ability to focus on work. This contributes to burnout and turnover. And so mentoring has been shown to play a critical role in enhancing supervisee efficacy and the relationship with a supervisor. Based on a scale of psychosocial support from Reagan and McFarland, that looks at friendship, role modeling, counseling, acceptance and confirmation, and advocacy. Now, this raises potential concerns because we don't necessarily want to be friends with our supervisees, but I think approaching it in an engaging, empathetic, and accepting way, using some of those skills from MI, replicates a work-appropriate, friendly interaction. I'm going to put up this poll really quick. Just those of you who are able to respond, this poll is asking you about your own experiences of stigma. And so thinking about your own identity, you can check multiple boxes. How many of these categories have led to experiences of discrimination or stigma that you may have experienced? Inadvertently, maybe somebody wasn't purposefully trying to stigmatize you, but it still came out based on an unconscious bias or an inadvertent use of a term or approach. So there are a number of different ways that we might experience stigma: gender, sexual orientation, race and ethnicity, class, socioeconomic status, health conditions, physical health conditions, mental health conditions, substance use issues, legal status, education. These are all potential experiences of stigma that we may experience professionally. And so, again, we talk about this related to clients, but we have to think about how we may inadvertently perpetuate different stereotypes or stigmas as supervisors. And I want to be very careful of that as I'm working with my supervisee. Good, we'll share these results now. And so again, 71% of you reported experiences of stigma related to gender. Race and ethnicity was the next highest, and it looks like education and class, and then others as well. Again, certainly this is not an exhaustive list, and I think there is a lot of stigma that exists in our treatment fields and in our communities in general, and we have an opportunity to try to reduce some of that, thinking about the type of language that we use, but also taking an introspective look at our attitudes and our beliefs, both in supervision and in treatment. Great. Thank you for responding to that poll. I know that can be a difficult topic to think about, a difficult experience to talk about or to think about. We might also see sometimes that some of our beliefs are different, or our values are different than our supervisees. For example, you might have a supervisee that believes that homosexuality is a sin, that people with certain skin tones are inferior, that their religion is the one true religion, that women shouldn't hold certain jobs, that people with certain disabilities should not be in the workplace. I hope that most of the individuals who enter this field and are successful in this field would have had an opportunity to confront certain biases that they may have that would not be conducive to creating a welcoming environment, and probably misplaced in to say the least. But these biases still come up. They still come up frequently, regularly in treatment, in supervision. And so we need to think about, what is it that we do when this comes up in supervision? If somebody says something that they attribute as just being kind of off color, but it may indicate that their beliefs or their biases are going to make them less effective at working with certain individuals. I'm going to come back to this. We're going to wrap up with that in just a little bit, but I want to give you a couple interventions or models to think about. Again, deferring back to the evidence-based, and we'll start with the trans-theoretical model. I assume most of you are familiar with the stages of change. Again, we've reconceptualized denial to pre-contemplation, because denial means you have to suffer more before I can help you, whereas pre-contemplation indicates you're at the beginning stages or you're not quite thinking about it. I have a task that I can complete. This wheel and the corresponding slide of the 6 different stages give you a sense of how those stages progress, what the definition is, the primary task, and then what a provider can do in each of those stages. I'm not going to go through that because I presume that you're all somewhat familiar with that, but we do have a PDF of this that I'm happy to send to all of you along with the slides. You can print this out. I have this on my desk when I'm doing assessments. It's pinned on my wall just to orient me to where the client is. So I'm not outpacing them, so that I'm not in action when they're in pre-contemplation. I think that works really well with supervisees too. And so we have here an integrated model of the stages of change with the integrated development model from Stoltenberg and Delworth. I'm assuming you're familiar with the 3 levels that they've come up with related to supervisee competence and how a supervisor facilitates growth across those levels and the proficiency. And this essentially breaks down what tasks we might focus on with a supervisee at each of those stages of change. It follows very similarly to what we would do in treatment, and I think this is a nice supplement to what we'll be talking about with MI and CBT, just to help everybody get on the same page. We talked about different mechanisms to provide feedback to supervisees that are structured, that are to some extent evidence-based. Doing staging with a supervisee to come up with a supervision plan might be a really nice place to start and model how this would look in treatment so that they could deliver a similar intervention using the stages of change. Once you get to level 3, that's a pretty self-perpetuating process in which you're facilitating and fostering independence. But prior to that, there will be different levels of focus that you have as a supervisor, just like we talked about with Sam, just like we talked about with Maggie, just like we talked about with Craig. How much work do you have to do to, 1, do some stimulus control to make sure that they're feeling safe? 2, how much self-efficacy or self-enhancement do you have to help them cultivate? And how much do you have to facilitate their autonomy? That's going to differ depending on the level that that supervisee is at. But this, again, gives us a bit of a roadmap thinking about the intersection between the IDM and the stages of change. 3 different evidence-based recommendations for treating co-occurring disorders. Medication-assisted treatment, particularly for substance use issues. We have sufficient evidence to indicate these medications are useful in the treatment of substance use issues as well as alcohol use issues as well as opioid use issues. I'm not going to go into what these do. I'm not going to go into the evidence base. Again, we have a whole separate training on that if you're interested in that. Happy to point you in that direction. But there's a solid foundation of research that indicates, and growing, that these medications are a necessary and worthwhile tool in engaging people in treatment and keeping them in treatment. And yet, when we run focus groups around these medications, we hear things like, medications are drugs. You're not clean if you're taking anything. Methadone is a drug and you're not doing anything but substituting it for another drug. In my eyes, you're still using until you're totally off. We've heard this from a doctor, believe it or not. I'd rather see that client on heroin than methadone. Methadone clinics are nothing more than substitution stations to feed addicts and cravings. They're a sought-after source to receive a legal addictive drug. And we've heard from other providers, I don't see why that client should get to use a medicine. I didn't have that luxury when I was getting clean. It's a cop-out from doing the hard work, as if there's something to be said about not using all the tools at your disposal to move through recovery. Again, I don't know that there's necessarily ill intent behind all of these statements, but there's a certain degree of realignment that we might have to do in supervision to defer to the evidence base, to confront biases and how that translates to treatment if we're hearing these kinds of statements. Let's see. Oh, some good items in the chat. Age is another one. Good. Too young or too old for the field. Yeah, I don't know what the sweet spot is for treatment, but I've certainly gotten the too young. I can't wait for the day that I get too old. That's coming quickly, I'm sure, with adolescence. Don't forget age for the future poll. Very, very good point. Yeah, I appreciate that. Age is a critical one when you're thinking about the dynamics in working with children and parents. You might see that children will presume there's an alignment or an alliance between you and the parent. Good. Clinicians experience adulting. Yeah, good. You might see that from the clients as well as from providers. Great. Excellent. Excellent. Thank you for that suggestion. Very nice. So remember, language makes a difference. If we're talking about medications, call them medications. We want to separate that from drugs. Drugs are substances that people will use illicitly or not as directed, whereas medications are tools that we have to hopefully mitigate some of the effects of mental health and substance use issues. This is a critical distinction because we want to get used to using language that promotes certain tools as relevant tools in treatment. Remember, we are ethically bound to utilize evidence-based practices as much as we are able to. Personal belief may come into conflict with that, but to the extent that we're able to, we have to ensure that we're using empirically based information to guide treatments. Good. Again, I'm not going to go over MI. I will direct you to a couple different links at the end. There is MI STEP, M-I-A-S-T-E-P, which is a supervisory manual that's published by in conjunction with Bill Miller and Steve Rolnick, who came up with motivational interviewing. That helps supervisors develop motivational interviewing capacity. We have a 4-hour self-paced MI course that you all are welcome to take for free on our website. CEs cost a little bit of money, but you can take the course, you can share it with your friends. And so if you're looking for more MI-specific information, there are resources for that. We're not doing that today. But what we will focus on is what is the role of MI in clinical supervision? A functional alliance is critical for a supervisory relationship. And we know that at the heart of motivational interviewing is that opportunity to enhance a working alliance. We see that anxiety can often arise, just like that Craig example, of certain clinician dialectics, how they feel like they are versus how they are, how they want to be versus where they're at. And uncertainty of supervision processes may manifest as resistance in those different clinical supervision interactions. We want to navigate supervising anxiety using a directive approach, or we want to navigate supervising anxiety. And when we use a directive approach, we increase defensiveness, just like with motivational interviewing. And so while I have to be directive at times when it's related to work performance, I want to be careful that I'm not always being prescriptive, because that's not going to help the examples that we looked at with Maggie, with Craig. That's not going to help them feel comfortable in bringing up situations where they might have an opportunity to learn and grow. Research shows that self-paced MI courses are ineffective. Even though I just advertised the one that we have, it's a good starting point. Continue to pursue training, but embedding MI skills in a supervisory context, doing consultation groups is one of the best ways to consolidate and utilize those skills longer term. And so there's literature that supports that. I'll provide you with the link to that MI STEP manual. The 4 processes of MI fit really nicely with how we might promote supervisee efficacy while still maintaining that directive focus on clinical goals and work performance. There are some limitations to this, however. The use of MI presumes proficiency in recognizing the limitations of a guiding style. It means you're proficient in MI and you know when you should defer to a more directive style. Safety or ethical issues have to be addressed directly. We can't sit back and do the motivational interviewing enhancement all on its own. We have to be very, very clear about safety and ethical issues in supervision. While there is a natural fit between MI and brief MI interventions, we need more research on determining whether or not MI on its own is effective as a supervisory interaction. So components of it certainly intuitively facilitate development of the relationship, but we need more specific evidence-based information with design studies to determine whether or not this is a worthwhile supervisory tool. MI supervision also lacks an intervention match, so you would have to bookend it with something like IDM to be more developmentally aligned with the supervisee. This is a frame for a brief intervention to use potentially in supervision. We use this in clinical application when you're working with somebody in a brief interaction. As little as 5 minutes, 5 to 10 minutes of this type of MI has been shown to increase willingness to change. And so if you're thinking about just dipping your toes in MI in clinical supervision, think about this frames approach, providing feedback to the individual, but doing that with some degree of empathy. So you're providing feedback to summarize what they've accomplished, but you're doing it with empathy around their struggles, with the difficulties, with their attempts to succeed. The responsibility comes back to always putting it on them. I'm here to support you, but again, ultimately, this is your responsibility to make sure that you get this, this, and this done. So help me understand how we might be able to develop a plan around accomplishing that. You're welcome to give advice, but always do that in conjunction with a menu of options. So in order to get all the things done that you need to for your clients as well as your notes, I would recommend that you write down hour by hour everything that you need to do. But there are some other things that you might be able to do. You might be able to just block out certain times each day to spend on client-related tasks. We might be able to spend a little bit of time in supervision, coming up with activities for the week, et cetera, et cetera. Which of those would you like to start with, or other suggestions that you might have? And then always enhance self-efficacy, that despite what somebody is bringing to you, we take the perspective that people are trying to do what they can to help clients with that value in mind. And so I want to cultivate that in supervision. CBT is really effective. Again, we talked about the way in which structure, consistency, predictability all enhance prefrontal cortex functioning. And so if I can model that in supervision, that might be a way to utilize some different cognitive behavioral skills that the supervisee can then use with clients. Have an agenda for supervision. Be organized. Ask your supervisee to summarize their work that's done in session and agree on homework assignments. Homework doesn't necessarily mean that they have to go home and read through articles. It might just be planning ahead for how they're going to get the worksheets that they need for that the next session ready, how they're going to plan what they need to take into the field ahead of time. Always incorporate feedback, just like we talked about. And at the end, what did you think of supervision today? What would you like to do differently in our next session? And then always directly model, again, that structure, that predictability, and that consistency as much as you can. It's almost impossible when you're doing face-to-face supervision with someone, but minimize distractions. Don't answer the phone if you can avoid it. Don't have people knocking on your door constantly. Keep the supervision space sacred as much as you are able to, because that conveys that you value that time as much as you're hoping the supervisee does. Theoretical orientation does affect supervisee perception of the supervisor. When supervisees perceive that their theoretical orientation model matched their supervisor, they felt that their supervisor was more effective. That makes sense if you're speaking the same language. Cognitive behavioral supervisors were perceived to play the consultant role more, whereas humanistic and psychodynamic were perceived to play the therapist role more. But there was no difference between the two groups in how frequently they were perceived to be a teacher. And so there's still an ability to impart information regardless of your theoretical orientation. Again, there isn't a lot of research, a lot of high quality empirical studies that show the impact of CBT in a supervisory context. So this is all fairly new in terms of how this develops in co-occurring disorder substance use treatment and mental health treatment. There are studies that indicate that CBT can be effective in development of supervisee skills, but there's more research that needs to be done, more additional rigorous evaluation. Just some additional tips. Again, careful continuous assessment is key. Note that withdrawal from depressants, opiates, stimulants may include anxiety. During the first month of abstinence, depression symptoms may fade, but it all depends on the individual, how long certain symptoms last. Related to affective disorders, Providers have to differentiate between mood and anxiety disorders, common reactions to different substances. Although it's true for most counseling situations, this is critical that you maintain a calm demeanor and a reassuring presence to engage clients. Start low, go slow, meaning we're breaking this down into individual components as best as we can. That corresponds with the structure and the consistency of CBT. Learn small skills before combining that into larger recovery-oriented coping mechanisms. The psychotic disorders, again, we want to teach providers the signs and symptoms. It's also important to develop differential diagnosis in an ongoing way. Anticipating and planning for crises is going to be critical. You want to provide frequent breaks when you're working with an individual with psychotic disorders. Shorten sessions or meetings, meaning you might have to break down the type of information that you're trying to convey into smaller pieces, and then monitor ongoing signs of relapse and return of psychotic symptoms. We're going to do this as a poll. I want to see what your responses are. A supervisee tells you about a client who had been hospitalized and discharged to your outpatient program. The hospital paperwork reported command hallucinations, destructive content, but not presenting immediate risk. The client was living in the park at the time, but has been linked to transitional housing since the discharge. Supervisee states that during the assessment, the client reported using kratom while living in the park and has a history of low-dose Vicodin use. Supervisee believes the command hallucinations were misidentified as an organic psychotic disorder and believes instead that the hallucinations are a re-experiencing of and difficulty coping with significant past trauma and PTSD. So I'm going to leave that up there for you, and I'm going to put up the poll just to see what you would do. Based on research that treatment of PTSD symptoms shows improvements in substance use disorder symptoms, while the opposite is not true, how would you advise your supervisee to proceed? Recommend treating the opioid use first, recommend developing a trauma narrative first, or recommend treating them concurrently? Seems like most people are voting for concurrently. Good. So concurrent, I think, treatment is going to be critical. That is the recommendation. Again, everything that we're talking about here, it's important to think about doing this all together. At the same time, it may be worthwhile to think about working with your supervisee in a way that does break out the tasks to be completed. And so when I'm thinking about addressing trauma and substance use issues, certainly I want to build up to the trauma narrative. But if you're focusing on developing recovery-oriented skills for something like opioid use issues or even kratom, the same skills will generalize to getting that person ready to develop a trauma narrative. And so it may help the supervisee to conceptualize a kind of developmental process of this treatment plan by thinking about what skills would I utilize to address substance use initially, folding in the mental health component so that they don't get overwhelmed trying to treat all of it all at the same time, all at once. Good. Thank you all very much. Good. So it seems like most people say concurrently. I would agree with that. Certainly we would not want to start with the trauma narrative. That would be the wrong place to start. Great. I'm going to skip now to special population considerations. And this is a little bit of a mixed bag because we've already covered quite a bit in this session. But in our conversations with Dr. Goodyear and Dr. Fellender, I think we'd be remiss if we didn't talk about additional special population considerations. When we talk about culture, when we talk about bias, it's critical to focus on some of these special populations because of the high rates of co-occurring disorders that we see among them. And so while this is going to be just a really brief overview, I'll give you some different tips, and then we'll start to get into our last activity of the day. We're right on time to where we need to be. So we're going to talk a little bit about special population considerations before we get to that last activity. Before we get into this, any questions that you all have that I haven't caught in the chat, anything that's come up related to the information up to this point? You all have been pretty good at putting your information in that chat window. Okay, great. I'll keep an eye on that. If anything comes up, then we'll be sure to address those questions. Good. So special population considerations. The first one, homelessness and co-occurring disorders. Housing is a critical social determinant of health. We know that this impacts health across a wide range of targeted health impairments or diagnoses. In 2010, 17% of adults enrolled in supportive housing had co-occurring disorders. That number has steadily been increasing, 22% in 2014, 25% in 2015. You see high rates of severe mental illness and alcohol use disorders among homeless women, 4 times higher than the general population, and any substance use disorder was 12 times higher. And so when we think about homelessness, case management plays a very specific role. We talked about this related to the SAM scenario, that yes, I want to incorporate those nuggets of therapy, of counseling, but I really have to think about how can I link this person to housing? How do I get them into a stable environment? Because without that, it's almost impossible to do the kind of treatment work that we're talking about related to substance use issues or mental health issues. That's not always going to be possible with every client. There may be some clients that, based on their trauma history, based on what they've been through, they may feel more comfortable being homeless than being in 4 walls and a roof. And so I have to respect that individual approach as well when I'm thinking about the balance between case management and therapy or counseling. Let's see, El Madrigal said, where did the poll take place? This poll, I assume you're referring to the poll of homeless individuals. This is a combination. This is a couple different studies. One was a nationwide study, and then I think it's the increases in 2014 and 2015. What we're seeing is specifically in LA County that we've looked at. And I know there was a recent homeless count in LA County. I don't know those numbers off the top of my head, but I would imagine that the rates are a little bit higher. Yeah, good question. All right, so this may be, we're going to shift now away from homelessness. Again, homelessness, it's important to think about the balance between case management and the therapeutic process and really carefully planning that out like we saw with the SAM scenario. Christine, the not-so-secret admirer. During group supervision, Christine tells the group that one of her clients is progressing really well with his parole. She notes that he's been incredibly compliant and responsive to treatment recommendations, following through on utilizing coping skills, as well as seeking community support such as NA. It appears likely that the client will be released by the courts. You praise Christine's diligence in following a structured plan with the client. Christine adds that while she's happy for the client, she's a little concerned because the client recently wrote her a letter that professed his love for her and his desire to continue a relationship ongoing. Upon hearing this, a number of other supervisees expressed their concern. One supervisee tells her, look, you can't mess around with that. I know things are going well. I'm sorry, this is a really risky situation for you to be in. We've all been around these guys and know what it could mean when they get attached to someone. You need him off your caseload immediately. Other supervisees appear to endorse this statement. Happy to get any feedback from the chat around this, but what I want to segue this into is that we recognize that there are high rates of co-occurring disorders among offenders, but we also know the way that we approach treatment with offenders dictates the success of that therapeutic relationship. If we adopt a Theory X approach that identifies offenders as liars, antisocial personalities, cheats, cons, evading in order to escape consequences of their behaviors, or unmotivated to change, we get into this process in which, just like with that example of substance abuser versus use disorder, we have to confront, coerce, correct, and control behaviors and make them change via compliance rather than working in a partnership. And we know that this type of behavior change is not long lasting. It may work in the short term, but there's no real research that indicates that this type of approach is effective in creating lasting behavior change. Instead, we adopt a Theory Y approach, having your own personal motivation for change, needing to be drawn out, that people are resourceful. They often want to change and will be able to make their own choices. When we adopt this approach, more consistent with a motivational interviewing approach, people feel empowered, they feel respected, they feel safe to explore and challenge uncomfortable situations. And while this doesn't mean that we reduce our focus on barriers with individuals in treatment or boundaries in treatment with individuals, we have to think about how we can involve them in their care. So do we have more current information on percentage of co-occurring disorders with clients who also suffer from severe MI and homelessness? I've seen a much higher rate of COD with those suffering with mental illness and homelessness. Yeah, again, I think the most recent survey out of LA County, I don't know if there's anything nationwide, but I think LA County's homeless homelessness survey did produce much higher rates. I think it was upwards of 60 or 70. I'd have to go back and look at that specifically. But that particular participant pool was significantly higher than what we're seeing here. Yeah, I'd have to review those numbers. Really good question. I know that there's more and more focus on doing up-to-date homelessness counts. And again, maybe we'll have a greater opportunity to do that if people are being placed into housing with the current COVID crisis. I know that there's efforts to put people into housing. We might get more information if we're able to link individuals in that way. But again, yeah, I'll see if I can find that link for you all and include that with the information. Good. So co-occurring disorder treatment with offenders should focus on building hope, recognizing the client as an expert in their own life, not necessarily deferring expertise to them, but having an opportunity to establish some collaborative relationship for emphasizing personal choice and demonstrating respect, find common ground, and emphasize values that are critically important. We recently completed an initiative with the Department of Corrections in California where we were training 7 different sites across the state on delivering a manualized group treatment for co-occurring disorders, illness management and recovery, developed by Kim Muser. And I'm happy to talk more about that, again, offline with some of you. I'll include that as one of the resources. It's a good starting point to do that kind of structured, planful work that we talked about. And it does raise some interesting conversations in supervision, because oftentimes providers know how to do CBT, but they have trouble in applying the degree of structure that's beneficial for co-occurring treatment with this population, and that provides a lot of conversation in supervision. We have a full day, actually it's a 3-day LGBTQ training for providers. I've distilled that down to like 3 slides. By no means does it do it justice, but I want to just really quickly note some of the challenges that supervisees may experience in working with individuals in the LGBTQ community and the rates of co-occurring disorders. We're going to skip Jeremy for right now, but we'll come back to that. Tips for supervisors: be aware of definitions to terms and how terms can evolve rapidly. Provide opportunities for providers as well as yourself to confront bias. Be aware that we may not always be aware of our bias, and know that getting feedback is a good way to try to address that. Understand the interplay between mental health and substance use issues and how minority status contributes to that disproportionality, particularly among individuals who are part of the LGBTQ community. Stay up to date on policy and legal issues and how that impacts clients. Identify opportunities to engage the community as stakeholders. Continue to pursue training for staff and yourself, and when in doubt, adopt a humanistic approach and learn together. Terms are rapidly evolving. As soon as we put this list together, there are additional terms in different communities that are being used. We use this to try to orient individuals to how we understand different terms within the LGBTQ community, but by no means is this exhaustive. By no means is this meant to be comprehensive, but it is worthwhile to orient yourself as well as your supervisee to terminology and use of terminology that is inclusive. We see high rates of alcohol use and substance use among individuals in the LGBTQ community. We see individuals who continue to drink heavily into their later life. We see that gay men are 7 times more likely to have attempted suicide. Gay youth comprise 30% of deaths from suicide annually, and gay and bisexual men have higher rates of deliberate self-harm. All of this, again, indicates some degree of disproportionality, but I think it's also worth noting that research is not easy to come by. Evidence-based treatment recommendations are not easy to come by, and so having community stakeholders, having an opportunity for conversation is critical in thinking about developing good programmatic interventions for individuals in this community. Some recommendations from the supervisory standpoint: get a complete history, sexual health assessment, avoiding assumptions or judgments. Meaning, if you're asking somebody about their partner, don't presume that their partner is the opposite gender of themselves. If somebody is married, they may not necessarily be monogamous, and so it's important to be able to ask these questions without judgment. If a provider feels uncomfortable working with this population, seek supervision. See if there are any issues or feelings that they need to work on, and if that can be managed in a supervisory context. Emphasize your ethical obligation to be able to treat everybody equitably. As a supervisor, observe staff interactions with an eye towards unconscious biases. have a zero tolerance for any discriminating or stigmatizing language. That doesn't mean that I might fire somebody simply because they used a term that was discriminating or stigmatizing, but it might. And so again, I have to think about how that relates to our organizational policies. Again, we talked about ethical practice. Your personal beliefs are yours. Keep them as such. If it bleeds over into your clinical practice, that's something that has to be addressed in clinical supervision. But we have a responsibility to make sure that people are equitably and are treated equitably and free from discrimination. Examples of unconscious bias that you may hear: I have no problem with gay people when they don't wear it on their sleeve. She's really pretty. I couldn't tell she was transgender. How do you know you're gay if you've never been with a person of the opposite sex? Again, I've heard these in different settings in different ways. Again, there may not be ill intent behind it, but certainly that's bias that perpetuates stigma and discrimination. We also might not be aware of some of the biases that we might have. And so take the opportunity to have open dialogue with your colleagues, with your supervisors. Acknowledge, yeah, maybe I don't know the right terminology, and how can I best find out the means of learning that. Certainly we should never be recommending therapy that attempts to change an individual's sexual orientation or gender identity and expression. That has been widely discredited and banned across the country, but is still used in certain pockets, unfortunately. As a supervisor, address transference and countertransference issues, ensure staff use ethical and evidence-based practices, consider organizational policies that are LGBT informed, such as taking the opportunity when you introduce yourself to use your pronouns, and invite staff to become comfortable to do the same. Ensure that staff are not discriminatory towards minorities. Regular scheduled supervision communicates that staff are supported and cared about, and so maintain that supervision time. And I think staying up to date with providers is critically important, as well as continuing to obtain training for these different issues. Good, so I'm going to move us into our last activity, and what we're going to do is we're going to go back to, here, I'm going to put this up for you. I'm going to move us back to Jeremy, and Jeremy provides an update on a manualized co-occurring disorder group session that is being run. Jeremy states, I can tell a lot of the group members are part of the LGBTQ community. I'm just not really sure that I need to focus on that. There are so many different terms, and I don't even really understand transsexuals. I feel like people just need to focus on developing their skills to manage their substance use and mental health that the group is about. It's stressful enough to manage everything without having to worry about another mental illness. So I'm going to put this vignette in the chat, and what I'm going to do really quickly, probably for just about 8 minutes, is I'm going to have you break out into groups. And so I'm going to break you out into groups. You'll be in a room with other individuals. And I just want you to kind of talk through what you would do, how you recognize this individual stage of change related to supervision, and what the critical focus might be for you as a supervisor. So I'll put the information in the chat there. There's the vignette, and then I will also put the information about what you should be looking for. Just so you have a chance to talk with one another. I wouldn't worry too much about the frames approach unless you really, really want to get into it. But we'll just spend, again, about 7 or 8 minutes in our breakout rooms, and you'll have a chance to talk with each other. So you'll see a pop-up on your screen if you haven't done breakout rooms before. I'm going to create those rooms. Just go ahead and click join that room. All right, so the breakout room should be closed. Now everybody should be back. So I'm going to re-share my screen. And, all right. Good. So hopefully you had a chance to talk about that very, very briefly. Again, there's a number of potential considerations that come up in this case, one of which is terminology. Using the term transsexuals is outdated. Equating gender identity with a mental illness is also a misapplication of understanding mental illness and mental illness diagnoses. And so I think with Jeremy, you might want to, this came up in a couple different groups, you might want to not marginalize Jeremy's experience, understand how he came to understand this, but find some way to provide additional education, additional training. The key with that is training is great, but in order to understand biases, I feel like it's important that an individual understand the value behind the recommendation. That we're not saying we're using these terms just because it's in the zeitgeist and it's popular. Using the incorrect terms really does marginalize an individual, and helping a provider to some degree experientially understand the impact empathically or empathetically is much more effective than just attending a training. And I think that's really where supervision comes in, where there's an opportunity for supervisors to drive that point home, really with an eye towards enhancing provider competencies. And I'm happy to hear any other thoughts around that, but I know we're kind of getting close to the top of the hour, so I want to be respectful of all of your time as well. So I'm going to jump to additional resources that I mentioned throughout today. Again, these two websites have quite a bit of information if you're looking to enhance your skill around something like motivational interviewing. The 4-hour self-paced course is, again, free of charge to all of you. We also have a screening and brief intervention skill course that's free of charge. Feel free to take a look at those. The MITI, M-I-T-I, Motivational Interviewing Treatment Integrity Manual is a supervisory tool to score motivational interviewing techniques among supervisees. I wouldn't recommend doing that without specific training, but it might be a good starting point to orient yourself to what to look for if you're listening to an audio taped session, if you're listening to, or if you're sitting in with a supervisee, which I highly, highly recommend. And then the other treatment manuals that we've talked about, the Matrix model for intensive outpatient addiction treatment is a manualized treatment that is well-researched, illness management and recovery for co-occurring disorders. And then you can access all of our YMSM LGBT Center of Excellence materials at ymsmlgbt.org. It's actually the shortest we could get that acronym, believe it or not. We workshopped that quite a bit. But we have webinars posted there. We have trainings. We have materials that you can use as providers. And so I hope that you're all able to access those as much as needed.